A case of multiple myomas in young unmarried girl. Hysteroscopy. First, I am doing a diagnostic hysteroscopy. You can see the fibroid polyp protruding. The origin is from the cervical canal. You don't need to dilate because it was already dilated because of multiple myomas. It's very important that we confirm our preoperative findings, which has shown on a sonography that there are multiple myomas. Try to take these cases on immediate postmenstrual phase. This patient had a severe menorrhagia and now breakthrough bleeding even during menses. First is a diagnostic hysteroscopy to evaluate how is the cavity, the situation of multiple myomas. Now in such patient, always take a consent of 2 sittings or 3 sittings. It's not only the fluid distension, but you don't want to take out from at all the walls at a time with energy source used because it may cause intrauterine adhesions. These patients are very tricky. Don't give a GnRH because these small tiny myomas may disappear for the time being and then will reappear later. So giving a GnRH is never a solution. Instead, doing in 2 or 3 sittings or careful is important. Here I am trying to show all these myomas once I analyzed. I am passing my bipolar energy loop inside and I will be doing myomectomy step by step. Now, what you want to or you should be noticing in this is I am taking out the myomas from the base. Sometimes I'm enucleating, sometimes I'm just using a cold knife, while sometimes I'm using an energy source. Now let's start always from one cornu or the fundus and then start going down. I'm just testing how is the energy source working. Now, if you notice it, the fibroid or the polyp, how will I differentiate? The polyp will not give you, can you see that base? This is typical of myoma. So these are the fibroid polyps. You can see all these things. You can very well differentiate between the myomatous tissue and normal tissue. So you are just judging by taking a small snip how deep it is inside. It was looking like it is very superficial, but it is not superficial. So I'm taking a small, thin slices out, trying to see that I will not use undue energy source. You can differentiate very well the healthy myometrium and then this fibroid tissue. These small strips are very important. Don't snatch off the big loop inside the wall because then you are going to take out her basal endometrium. And if at young unmarried stage she has so many myomas, we all know that these myomas will recur as soon as what I mean is at the immediately. So be very careful while taking out, and you can see that thin 1-2 millimeter strips I am trying to take out. If there are thin strip you can keep on, I may give a post-operative like fibronorm or anything which can take out these small myomas, or I have used the energy source to that tissue so that myoma will get myolized as well. Now this is a little larger submucous myoma. Now the base is still down. I don't need to keep on enucleating. I can directly attack the base. Now, what is important is it a type O submucous myoma? Then you attack the base, everything will be fine. But if you see here very carefully, it has a little invasion into the myometrium. So this is a intrauterine part. I'm just trying to use sometimes the energy source and sometimes I'm trying to push off so that I don't have to cauterize to the base and I'm just snipping off that, making thinning of the pedicle. So these all small tips I'm trying to share with you. You need a patience, you need a complete understanding how the myoma works, and also you will see in this video I have not taken out my loop or a resectoscope a single time. I finished the entire surgery, then only came out, so that there is no too much of a bloody vision where I need to wash off with lot of normal saline fluid. Some part of a endometriosis or adenomyosis you can see there. Now what I'm doing is, look, it was looking type O, but it is not type O. It has a small extension in. You very well can differentiate the myometrium, the basal layer, and this myoma tissue. Just try to increase and decrease the pressure of your intrauterine cavity. What it will help in protruding, what sometimes those myomas you can just protrude them out by just changing the intrauterine pressure. You can see I'm just sometimes just give a small energy source there. How in laparoscopic 1 centimeter multiple myomas we can do myolysis, same way you can do it here as well. Now the loop sometimes you are watching, I'm pushing towards the fundus. You need to have a very strong control in your hand when you use the loop in a reverse direction, that is from downwards to upwards, because if you use a little more force, what will happen is you will never know when you have perforated. What I'm trying to do here is, with the loop, I'm trying to enucleate the myoma. Can you see that? That piece has come out, and I'm just trying to enucleate. Then this is the healthy bed, and I'm sometimes you have devascularized it. It can undergo degeneration on its own as well. Since there are multiple fibroids, they can be intermingled with each other. So just try to take a snip and watch. Yes, so this is a piece of a myoma while this is a naked bed. So if I finish on this side, then I will go. In this case, the other challenge was the internal os was widely open. So it becomes difficult to maintain the pressure and lot of bubbles will come in. You should know how to navigate your passage through this bubble. Allow this bubble to little bit disappear, and then you take the next myoma. So I always feel inspection through your 2 mm or a 4 mm telescope before you start the surgery is very important, so that you can analyze which are the myomas, which are big, which are small, and then you can slowly attack them. You will see that these are the anterior myomas I'm trying to hook out, take out, resect out, washing the fluid, washing the blood stain fluid, sometimes just passing the loop, allowing the pressure to decrease so that the myoma may get protruded in. Can you see? But when you decrease the pressure, again, these myomas, when they are multiple, your space get narrowed out. This is a myoma. I can very well differentiate. It is protruding in the cavity. I'm gently trying to take out. You just see, I have not withdrawn my telescope. I'm just using small bits, small slicing, and trying to take out as many as in one go. You need to have a dedicated resident or anesthetist or the ward boy who can manage and who can keep on counting your inflow and outflow. Now I know on posterior wall I have used the energy source, so I'm trying to be as superficial as possible, trying to take small bits and pieces, then hooking the loop completely inside. So try to go beyond and then come down. Try to see if you can just hook out and take it out. How in an open laparotomy for the myomas we used to use our fingers to enucleate. Similarly, without the energy source, I'm trying to just take out complete base. So this is very important that I'm not using any energy source, and you can see that this is a capsule of the myoma which is coming out, and I'm just trying to take out all these small pieces or the bits. So this is a cold knife without the energy source. Sometimes, as I say, now this was a fibroid, so I'm trying to see if I can just enucleate out that, attacking the base. Sometimes the base may be thick, you may spoil your loop. So what I'm doing is I'm going just with the little energy and then taking out the base. This is very important to have a control in your hand. Now this is a small piece, I can just enucleate out. I definitely believe that if you use a energy source here on the myomatous tissue, it will undergo little myolysis as well, and you can afford to keep this thinner tissue than trying to take out everything, because definitely you will avoid damage to the basal endometrium. Remember, this lady is unmarried girl, and she is having her huge obstetric career ahead, and we don't want to land up in damage to the cavity. It is not Asherman alone, but also the vascularity. So can you see how in the farm you can just, do the rooting of the ground? Same way I'm trying to do. Very well, you can differentiate, finish up one by one wall and try to take out as many. I am just still in the mid cavity and I'm trying to see now these elevations. These are nothing but the myomas. So just use gentle loop. Can you see that? That was a myoma. You have to have a feel of it, decrease the pressure, it will bulge inside, confirm your finding, and then resect it. Again, what I'm trying to do is enucleation with the cold loop. So many of these small myomas, I'm just enucleating. Can you see? Now from anterior wall, I reach to the right lateral wall, and now I'm trying to go on the posterior wall. Between 6 o'clock to 9 o'clock position, I'm clearing this wall. So without energy source, the cold knife, and I'm taking it out beautifully. So it's not easy all the time to take out like this the base, but sometimes you can do. It depends upon what cases. Every case is different. No two myomas are same in their position, in their sizes, in their consistency, in their behavior. They behave differently. So when it was not coming out, I can just use little bit current and take out and slip out. So we have finished nearly the posterior wall also. Here I am not much happy. So again I am taking out that polypoidal tissue also. So this is quite a bulbous appearance. If you don't take out this will reform. Can you see? There was a tissue. This is different look. You can absolutely say that this was a fibroid polyp only. So take out this all fibroid tissue. Many a times you will break your loop when you are not using the energy source. So you should have a judgment with you. When is the tough tissue? I can use some energy, and which is the soft tissue where I can get along without energy source. It is not only damaging or cutting the loop, but also if you see the angle of loop also gets changed over the period, because you are just pushing in a upward direction. What will happen is it will make an acute angle with your shaft. So be prepared. But what I'm trying to do is I'm avoiding removal of my resectoscope. I'm trying to watch. I'm just trying to see how many myomas I have removed. I have gone to the right side of the corner, and I know this tissue I need to resect before I go on another wall. So I'm just trying to take out this. This is, have a very broad base. So be very, very gentle when you go to the cornwall side, and then try to snatch off. This is, I'm showing you complete unedited video so that the teaching will be better. You see, with your fluid pressure, the other pieces which you have removed, they remain out of from the field. Or keep on working, they automatically will move. Now I know this 6 o'clock here, it is a little tough tissue, but very gently I'm trying to go and trying to take out. This tissue doesn't look very healthy because it may be little bit element of adenomyoma there. So just try to take out. You can see that little bit adenomyotic tissue, or it was just a small hole. It may be a large vessel opening. The pressure in the uterine cavity is collapsing it. But you can make out the healthy tissue, the little bit brownish tinge in the tissue. So this patient will have in future again a element of a endometriosis. Now if you see on this side I had removed, it was not getting out completely. This is a little bulgy tissue. So I am just seeing whether by taking out the endometrium I am exploring a underlying fibroid over there. I'm just trying to remove the previously removed myoma and remaining piece. Yes, it is coming out beautifully. So I'm just trying to take out, but this bulge is definitely the myoma yet. So I'm just trying to resect out this piece. So what is important is hysteroscopy is an art. It is like a painting inside the cavity. You need a complete patience. You need understanding of these. Now the same patient would have been 45-year lady and still wants to conserve the uterus. I would have been little bit radical in taking out her all fibroid pieces, because it doesn't matter to her the basal endometrium is there or not. The only care I would have taken is not to have an intrauterine adhesion which can cause a hematometra formation, and she needing another surgery for that. So you can see on this side it was more of a polypoidal tissue. Very important to take that out, devascularize it so that it will get shaded off. So I'm just saying, sometimes this degeneration of the fibroid was not looking very healthy degeneration, but at the same time it's not a vascular. So probably I may not be much worried. I'm just pushing and trying to enucleate it. Can you see that? The different tissue? That tissue is nothing but the myoma. So if you would not have exposed it, you would have missed that inside. So nicely it is coming out, chopped out, and I think nearly 70% of the cavity is got cleared off. You can use then the ovum forceps easily and you can take out those. Now, this patient, am I going to finish in one go and say, yes, all is gone? No. This patient, I am going to put post-operatively on 2 milligram of progenova. Now, I am putting here little controversy. Progenova means estrogen. Now, if I am putting a estrogen, will it be a food for this? Look, I am just giving a look in the cavity all around. Am I going to then cause more myoma formation or small myomas becoming bigger? I am not worried of that at this stage. This is another polypoidal tissue I need to devascularize and I need to cut that out. Now, what is equally and most important for me is to regenerate from the basal endometrium the new lining of the endometrium, and that is why I'm going to put on a very small dose, and after 2 to 3 weeks I'll call this patient in my cabin to do the 3D sonography. Definitely one more sitting I will be going in. I'm not going to give any GnRH or fibronorm like material or drugs now. I will be watching her. I will be doing her second look hysteroscopy after 4 weeks. But definitely, I don't want intrauterine adhesion. If you see how nicely I'm using, see, this is a bulge, this is a fibroid. This is a small, but it is a fibroid. So if with the cold knife it's coming out, wonderful. But if it doesn't come out, you should be using an energy source and take that out. So, small amount of a estrogen dose to this patient will help me to have a nice endometrial lining. This case was taken immediate postmenstrual, so her ovaries, she had a regular cycle, so she will have her own. Can you see how nicely I'm just chopping it out? I'm enucleating it out. Beautiful. It's gone. So she has her endogenous estrogen also coming in, and that will also form a beautiful layer. After 2 to 3 weeks, I'll call her just to do the sonography to see how is her lining. I may expect hazy lining, that's okay. And then I will add on progesterone and get a nice withdrawal bleeding for her. Once she have a good withdrawal bleeding, on 4th or 5th day, I will again go in the cavity and see if there are any small myomas which have been missed out or they are still there. I will enucleate them. But before taking her on 4th, 5th day, again I will do a very good transvaginal sonography. Can you see many myomas? I am able to use a cold knife without energy source and I am able to remove these. These were quite soft, but definitely, can you see the difference in a tissue between the myoma, myometrium, and the basal layer? So, with the experience, you can do. So, all these, if you have noticed, this is an unedited video. I know there was one coming out from the cervical side. I'll be taking that last before I take out everything in the cavity. So, I'm trying to finish up. Now, I think I'm nearly at the isthmic level and I'm trying to take out as many from all the wall. Now upper cavity I may not be able to see neatly because it will be full of all this tissue which I have resected. So I'm just rotating myself from all direction. I finished upper half, I finished mid cavity and definitely I have reached to the internal os, and I am trying to just feel for the myomas, take out the superficial endometrium, and feel for any deeper myoma. So, in endoscopy, you don't have a tactile sensation, but you can have a sensation with your instruments. You can have a elevation look on the superficial area because no elevation is normal. So this is, I think I have reached almost to the, you can see now, I will be coming out slowly, taking out again. When you go 1 centimeter down, you try to take out from all. So I'm moving clockwise and anti-clockwise, and I'm moving 1 centimeter downward also. This poor girl, I just want to avoid her recurrence. Without energy source, I am trying to take out as much tissue as possible. And I am reconfirming. She was taken on a 5th day of her menstrual cycle. So I am confirming that yes, on lower wall I finished. There are no more. I have decreased the pressure to see. You could have seen a small vessels coming, and now this is nothing but the fibroid here. This is a little vascular, and see how I'm enucleating. I'm just trying to avoid, and a fabulous basal layer is seen there, and this is been erased out. Wonderful. So that myoma is gone. You can see these are the small elevation. Giving a panoramic view, giving a complete antero-posterior lateral views, all this is important. Can you see how these bullet vessels there? The moment I reduce or I come out, they will start bleeding. So I am trying to avoid coming out completely without finishing the job. Now this side I am done, this side I am done. I am going anteriorly, and look at this. I see there a small bulge again. So this is again a myoma without using an energy source. I've just enucleated this out. Very good. These were absolutely small, tiny. You do have a little magnification on a hysteroscope, but that's okay. Try to take them out absolutely from the base so that there is no recurrence. Now, posteriorly, I did not use an energy source, so even if I have to use little bit here, makes no difference because I'm not using at a time anteriorly as well as posteriorly. So this myoma from this side is out, and I think I can see now cervical folds. I knew that there was one more. So decreasing a pressure, as I said, will spoil my field. So I'm going in again, checking out and coming out. Now, while coming out, I know one in the canal is remaining, given a complete look. The fluid input and output, there was a difference of just 2 liters. So we always put the catheter and we give 20 IV Lasix to the patient so she will not go in a pulmonary edema. Because she had so many tiny 5 millimeter, 6 millimeter, can you see that these bulges? So I'm trying to see all these. Yes, so this is typically, You can just burn out these because there is no end to it. And try to come out. In 1-2 years, they will become big. Just do the myolysis on all around. These are the small tiny pieces. And this is nothing but the cervical canal, giving a look on an anterior wall also, and then trying to come out. There was no need of this loop because unnecessary. Can you see that? Immediately you can make out the difference in a myoma tissue also. Now this is the pedicle of my myoma, which was seen from a cervical canal protruding out. So I'm trying to see now my loop. Ideally, if I would have got a Colvin's knife, I would have been in a better position, but I don't want to change, and I'm trying to resect that, trying to weaken the pedicle because it was nearly 2 centimeter total. So I'm just taking out, thinning out the pedicle. Sometimes it is tricky to loop them and the pedicle is looped out. Try to remove this base also, otherwise new fibroid in a no time it will come out. Can you see that? The tissue has to come out. That is why you should, when any polyp or fibroid tissue comes in, just don't put the clamp vaginally and take out. Try and reach out to the base. Here, if I cauterize little deep, I don't have any problem because this is a cervical canal only, and probably I'm out. Thank you so much, friends, watching this video. I enjoyed this, making it for you.